szépen köszönjük, Terebessy doktor.
Nagyon jó, de most felszívott. Neki.
Jobban figyelnünk kell a megsportolókra, és ne legyenek hosszabbak, mint a világ végéről jött.
Szeretettel köszöntök mindenkit a finom ebéd után. Próbáljuk.
Good afternoon, everyone. I would like to suggest that everyone take their seats. We should move on with our program because, as you know, we also have evening programs. So while people are putting up my presentation, I would like to say thank you to the organizers. I think you are really a world champion in more than one sense of the way, more than one sense of the expression. So, I have changed the title to some degree, and I decided to speak about the possibilities and the limits of orthopedic interventions in CMT, DMD, and SMA. Now, foot deformities is an area that I would like to not touch upon because Mr. Pfeffer, the presenter right after me, will speak about that topic. Now, in my practice, I see a lot more SMS cases than DMD and CMT cases. So I will be quoting literature often. Let's start with scoliosis. I would like to talk about the conservative treatment without an operation of scoliosis in children. That's before the spine of this individual is operated by Dr. Tunyogi. So we have about 30% of cases where we have a left convex thoracal twisting, basically a curve in the spine. Typically, we don't know why this happens. Now, in orthopedic textbooks, we usually say that if you find this type of scoliosis, this curve,
300 beteg adatait földolgozva szintén azt
we should look out for a possible neuromuscular cause in the background. Now, in history, children with scoliosis were usually only diagnosed at about 13 years of age. Duchenne is a different situation. An independent Texan research group showed that this happens in 38% of this population of children. And there was a minor study as well, which made a statement, or at least an observation about DMD treated with a corset that is very tightly fitted to their bodies. You know, there are major difficulties with this treatment, but they found that in the initial stage, these curves, even though are large curves, they are also very flexible, and it is only later in their age that they become rigid. And during the flexible time, the corset treatment for children can be efficient, if you define efficiency as slowing down the worsening of the condition of the patients. So that's another indication that a corset could be a good idea early on, as early as possible. Now, we have also another study. I don't quite understand why my slide is kind of confused in terms of its graphics, but whatever. So we checked 24 patients with spinal deformity, SMA 1, 2, and 3. And we found that it was about age 9 when they visited us for the first time. And SMA 1, 2, and 3 frequency rates are given on the left pie chart. And then we tried to sketch up a relationship between the severity, which is the Cobb degree, COBB, the deviation of the spine from the straight line. And we have a very interesting result. It shows that the older children are, the less severe the curve is. But looking at this surprising data, we see that those children, older children, were only SMA type 3. So we split the chart into two, and with SMA 1 and 2, we have a straight line. The older they are, the worse the situation is. We were considering scoliosis of over 20 degrees, whereas in the right chart, we did not see any correlation between the degree of the scoliosis, and we did not find a correlation with the degree of scoliosis and the time, that is age. This is also a chart of the expected progression, the expected deterioration in the condition of the children with SMA 1, 2, and or 3. So these children, these patients were not necessarily treated from an early age on. We will continue recording this data and, so to say, purify or filter the data set, which also shows that progression is kind of weaker or more limited in type 3. Now, every presentation has to include one slide that completely confuses the audience. We like this chart because it shows how the arrows show what is related to what, and then people are trying to describe what's what. We don't have to understand this in detail. We don't have the time to do that. But the main message for me, at least, is that the motor function of children, which is directly related to their quality of life, depends heavily on their neck stability, on their upper body stability, and on the rate of their scoliosis, the extent of their scoliosis. So the more severe their scoliosis is, the worse their body functions are. And what we see in SMA as well is that in an earlier age, when the scoliosis is more limited, then a treatment with a corset, a Chenot corset, will help. When kids are not yet able to sit, but we still need to have them sit up, or if they can sit with very poor upper body tone, but maybe just supporting themselves with their hands or otherwise, then we should start applying the Chenot corset. And then I found some literature which said, let's use bracing proactively, because this is the line without proactive bracing when they only started when it was already as bad as 20 degrees. The more, the top So the chart shows that COB degrees that we can expect over time are much more favorable if we start using a corset proactively before even they reach 20% in 20 degrees in scoliosis. Now, let me talk about something that I also cover when I teach at the university. Let me show you how your hip joint works. There's a socket and there's a ball. And the socket doesn't cover more than half up to the equator, down to the equator. I'm talking about children who are not neuromuscularly compromised. We're just talking with people children who have dislocated hip joints, and then we have to treat them. Now, neuromuscular hip joint issue is completely different because their joint is completely healthy to begin with, but there is a muscle issue, and what happens is that the ball of the joint basically dislocates out of the socket because the tendons, ligaments, and the muscle are not strong enough to keep them in their place. Now, what I show you is a complex hip joint correction intervention, and this socket is basically chiseled out of the pelvis. It is turned rotated and then put back with metal fixtures, hardware, and it's supposed to help children. But if you have spasms, if you have other muscle problems, then this might work. However, in the case of SMA, when the muscles are not strong enough, then even you have executed an operation on them, the socket might still just loosen up and completely fall out of the joint. Can simply just fail to function. I apologize for the and we performed another piece of study on DMD where we have more of a consensus among professionals, which says that there is a correlation between the degree of pelvic issues with age. There is a straight correlation between the two. The older they are, the more displaced, the more skewed the hip is, the pelvis. And this basically means that whichever socket is higher up will be compromised and get dislocated over time. Now, checking our own SMA patients, we were able to filter the population, and so we only studied SMA 1, type 1 patients, seeing what factors play a role in displaced pelvic joints. And of course, we considered what treatment they were receiving, and we did not see a correlation. We also did not see a correlation between their condition and their gender and their sex. So what we thought that maybe age at the time of the first treatment is what matters a lot. In each of the cases we studied, they received drug treatment, nuciners, and then our software was able to show some correlation, weak correlation, but there's too much of a scatter.
Összefüggésnek, ami viszont erősnek látszik,
What we did see was that the higher the chop intent score was, the higher the chance of a dislocated pelvic joint was. So just very recently we had a conference of European orthopedic professionals working with children, and there was only one presentation that was dedicated to SMA. None of them were focused on CMT, and two were focused on Duchenne. Of course, we did run out of time at that conference as well, but there is no consensus on whether we should fix the dislocated pelvic joints of SMA type 1 children. And I would say I'm conservative.
nem tenném vissza, és ahogy hallottuk Kiara előadásával, ez meglehetősen egybe.
And as we have heard from Kiara's presentation, it's highly likely that they will not be able to walk independently outside therapy. And in contrast, it's interesting. I have indicated SMA2 in brackets, who will receive treatment already from childhood, and this will not have the same clinical picture as before, whereas SMA3s, where we most of the time detect displaced hips in their teens. This is the X-ray picture of a 10-year-old girl, and to my shock, I managed to move her left hip joint. And then I consulted spinal surgeons, and we agreed this level of scoliosis does not warrant an operation, so let's do everything we can to stabilize the pelvis.
And that was especially important because later I learned that this young girl was trying to keep this joint from actually getting dislocated. These two photos were taken at the same time, sitting and standing, which means she did not have the degree of scoliosis that we assumed. She only had a curved spine because she was trying to protect her own pelvic joint.
És egy másik csontból vett.
And so instead of fixing her spine, we decided to stabilize her pelvic joint. And this was the result. The photo on the right is her standing X-ray. We still have some scoliosis, but it looks a lot better than before. However, can we start the video? Can you help me with that? Okay, so the left one was before the operation. She was kind of throwing her leg to stabilize her hip. And then after operation, her walking is actually better, but her upper body sways more. So overall, her stability has not improved. So the musculus gluteus medius, the middle muscle dominating the butt cheeks, I had to move it away during the operation. And after it healed, its function became somewhat weaker than before. This is the story that we have. This is what we could achieve. I don't think we are operating too many children with this condition. I think I have operated on 2 or 3. Now, I also found another study that's kind of oldish from 1999, which shows that the curve that shows the ability to walk tells us that children who were operated on their soft tissues at around the age of 7, which could be the Achilles tendon or any other soft tissues, their results are actually better. I have myself never operated on kids in this age. This is when children usually come to us with contractures at the Achilles tendon. And maybe because of this, the failure of the last 2 operations make me say we shouldn't operate because we will not be able to help the children, and we will not help the family either, while we expose them to quite a hassle with the operation and the healing process. Now, I also checked a publication by Professor Achadi that he himself mentioned, and because he explained most of this, I will skip that part and close my presentation by saying that I think Professor Mona said that we need to encourage young people to join this movement, this team. And I was very much motivated at the conference I referred to earlier. For us to be here, you have to both do science and take care of kids. So obviously, people who join this team will not be driving the red car. But hey, thank you for the attention.
Hello, Glenn. Be fogom mutatni.
Let me now introduce Dr. Glenn Pfeffer, who is going to join us via Zoom. Can you hear me? Thank you very much.
Appreciate you being here with us. Oh, I can see you now. Hello. Give me just one more second. I will wait for the guys to give me the sign so that you can go ahead with your presentation. Are we okay? Yes, and we are okay. So you can go ahead, Glenn.
Remind me of one thing. What's the makeup of the audience? Who's in the audience?
We have some people here who have CMT or SMA, or their children have it. We have some professionals here, some parents, so it's a mixed group.
Good. Well, it's hard to speak to everyone, but I'll try.
Go ahead.
Let's see here. Hold on. Now, how do I do this? Share screen. Let me get this right here. Share. There we are. I love it when all this works. Hold on. Let's see here. Okay. Now, can you see that slide?
Yes, we can.
Can you see my first?
Yes, we can see.
All right, then let's begin. Well, good afternoon to you and early morning to me. I couldn't sleep well, so I changed this talk a little, starting at about 4 a.m. my time. So we'll see how the new version does. My name is Glenn Pfeffer. I'm an orthopedic surgeon in Los Angeles at Cedars-Sinai Hospital, and all I do is foot and ankle work. When I first went into practice, I did hand surgery and foot surgery, but the demand was so much higher for foot and ankle that slowly I gave up the hand. When I was in San Francisco for 18 years, and then when I left, I came to Cedars-Sinai in Los Angeles, and I've just been doing foot. For those of you who don't know Cedars, it was just rated the #2 hospital in the United States and the #3 orthopedic department in the United States. I'm not sure how all those ratings are done, actually, but it is the most prestigious rating, so we're all very proud of that here. I'm an academic employee. I'm not in private practice. I simply get my paycheck every about 5 years. So the things I do are not directly related to money, which is very good for me. I didn't like to be a businessman when I was in private practice. So today we're going to talk about CMT and the surgical reconstruction of what the predominant problem is, which is cavo-varus feet. Let's see if we get this all to work. Now, for those of you who'd like, you can look at all the work I do on Instagram. I'm a little embarrassed about this always. When I went into practice, if somebody did any kind of publicity, they'd be thrown out of the medical societies. But a 16-year-old patient once said to me, why don't you set up Instagram? And I did, and I think it's been very successful. And every Sunday, I talk to 3 or 4 people around the world by video chat for free about their CMT. But that's where you can find us at Charcot-Marie-Tooth Surgery on Instagram. So I wanted to do this talk because I really enjoy doing lectures or talks or talking to people across different specialties, because there's so much miscommunication, isn't there? It's hard enough for me to talk to another doctor, let alone a patient, about CMT, or at least it's easier for me now, but so many of you have problems with that. This video just sort of typified to me the importance of communication. So I wanted to share it with you. All right. How many of you feel that way sometimes when you're going to your doctor, right? So, as I said, I have nothing to disclose. I'm on the medical advisory board of the Charcot-Marie-Tooth Association, Hereditary Neuropathy Foundation, but nothing other than that. And I get no money for that. So, as you all know, in 1886, these fellows, Charcot-Marie, discussed or proposed Charcot-Marie-Tooth as a neurologic condition. They thought it was spinal related, centrally related. It was really Tooth in England who proposed that it was peripheral nerve related. My wife's British, and she always wants me to mention that. 100 years later, I just went into practice in San Francisco, and I saw my first CMT patient. I came into the room. There was a young woman there. I thought, what is this? An ankle sprain, some type of sports injury. She was very fit and live. And then she said to me, do you know what CMT is? And I had heard of it maybe in medical school. I think it was probably discussed in less than 1 second in the neurology class. But I looked at her and I said, oh, yes, I know what CMT is. It's what we'd call a white lie, for those of you who know that in English. And then I saw crutches in the corner of the room. And she said, she was probably 26. She said, well, that's good. I'm glad you know, because I don't meet doctors who know what it is. And she said, I'm going to show you something I've never shown anyone, my feet. And she showed me these gnarled feet. They looked like oak trees, twisted. And she said, I can barely walk. I've never been on a date, although she was a very attractive, very bright person. And she said, is there anything you can do for me? Well, that began my career with CMT because I researched this extensively. I spoke to a lot of people in the world, and it was obvious there was no clear consensus on what to do. But we did one surgery, and then we did the other, and then she started to date. And she thanked me, and then she got married, and then she had a child. And I think that was really the beginning for me. And it was hard to let go of that. Now I've done more than 700 CMT surgeries which I think assuredly has to be one of the largest experiences in the world for this problem, certainly in the United States. So when I first got to Cedars, this woman came in, 17 years old. Her parents had looked all over the United States for someone who they felt confident could help her. Her name was Sarah, and she only wanted one thing. She wanted to walk down the high school aisle without holding on to her father when she graduated. I knew a lot more about CMT by then. I operated on her, both feet, and here she was. She walked down the high school aisle. Years later, a few years ago, I called her up and I was worried. I said, Sarah, how are you doing? And she said, Dr. Pfeffer, you don't understand. I just walked around London for 3 or 4 miles in cute shoes with my family. I work in a pizzeria now as a waitress. I'm going to law school. So that really cemented my interest in this. I went to Cedars and I said, we need to set up a CMT center here. And then one thing followed the other. There she was, probably a year after her surgery. So people say to me, when will I retire? And when I look at a case like that, and I remember back to her coming in, I would simply say, why would I ever retire? Okay, you know about this, you've been talking about it all day. Very heterogeneous bunch of neurologic conditions with more than 150 genotypic variations. The phenotype, however, is fairly consistent. If we had to just, let's see, where's my computer? If you had to just lump this, there are basically 2 types of feet for me. There's the cavovarus high arched foot, not necessarily this bad, and then there's the flail foot or the more paralyzed foot, which is about 20% of patients. But this is what we're talking about today. We're talking about the cavovarus foot, which is so disabling to patients. Now, why does it happen? Well, I think, sorry, I'm just looking at my watch timer here. I think we, most of us know why this happens, but it's a muscle imbalance. Something very unusual happens in the lower extremity. Some muscles get strong, stay strong, and others weaken. And there gets to be a tremendous twisting unbalance that occurs. Now, there's a classic thought that, well, the posterior tibial tendon stays strong on the inside of the ankle muscles on the outside get weak, but there can be tremendous variation in this. What happens? The muscles in the toes unbalance, and the toes deform. The muscles in the foot become unbalanced. Without this unbalancing, with some staying strong, the foot would be flat. It might not move, but it would be a better foot than this, as it would be flat on the ground. When they're not flat on the ground, when they're crooked, as I call them, there's unloading, pain, unbalance. Of course, there's neuropathic pain. People with CMT have neuropathic pain often. But I would just ask you to talk to your friends. If you have CMT, speak to your friends tonight and have them twist their foot inward, take their shoe off, and just walk around for a while like that. It's going to hurt. So you can see by correcting this problem, the pain will be diminished. Not completely gone, but diminished. They're high stress areas, and right below this, often people get a fracture. The bone just can't tolerate that stress of walking on the side of the foot with hundreds of thousands of pounds of stress. Now, this is the typical type of foot we get in advanced cases. The tibialis anterior, the ankle extensor becomes weak, the perineal muscles weaken, the foot becomes unstable. And I see someone like this, at least twice a week, and she said, is there anything you can do for me? I'm told there's nothing that can be done. And often they've traveled thousands of miles for an opinion because they've never had any help offered to them by the medical field in the United States. And what you have is a very stiff, rigid foot, and it'll be driving like in a car with no shock absorptions, just like this. And that causes pain and suffering in patients. It's a tough disease, especially in this country when when a patient tells somebody, I have CMT, and the answer usually is, oh, is that the country music channel? All right, over time, the ankle become loose. And over further time, the ankle could become arthritic. Now, braces are wonderful. Look at this woman. She can barely walk without holding on to the door. Here she is in braces. It's life-changing. But she has a foot that's flat on the ground. She has a flail lower extremity. She's paralyzed below the knee. Nobody wants that, but much better to have that than to have the crooked foot. Now, there are many braces available in the United States. They're all of these different names. Some of them are over the counter. I'm sure they could be purchased in Hungary. I'm not sure they'll be covered by your national health insurance. But these are the types of braces, if you're paralyzed below the knee and your foot's flat on the ground, that you want to wear. These are called ground reaction braces, grapho braces. They are wonderful for the flat, split foot. The problem is they're expensive, $1,000, $2,000 US. They're made of carbon fiber, which allows them to have that flex, and they're very light, but it's brittle. It's brittle. We just saw a patient from Greece who lives in a town of cobblestones, and they said, you know, every 6 months they break the brace apart. So in those cases, a regular plastic AFO may be preferable. But for me, I haven't prescribed a regular AFO plastic type, probably for 20 years. So the question is who do we brace and who do we operate on? And that's the really key issue, isn't it? If you're a patient, if you're a doctor, who gets surgery? Who's going to benefit from surgery? Well, for me, it's very simple. You don't brace a crooked foot unless there's no option. Half of the calls that I do on these video chats on Sunday are from out of the country. They can be from countries where patients have very, very few funds. And maybe their only option is to brace their foot. I was just talking to someone or video chatting from India with a horrible deformity, but they have no option. So they'll put a brace on their foot. I understand that. But we're talking about the ideal situation. Don't brace a crooked foot. Please don't brace a crooked foot if you can all help it. Take this young boy. There's nothing we can do for you, as doctors said. Live with this the rest of your life. Look at the calluses that he has. And he's in a brace. And he lives in the Midwest. He's a hardy young fellow. And he does okay with his brace. There's nothing so, excuse me for a sec, there's nothing so miserable about that, except for the fact that he's miserable. And in Los Angeles and in the United States, the shame for me is no one's given him an option. The brace people keep making braces. Many of the neurologists here just look at CMT as a neurologic problem that can't be helped with surgery. And no one's given him the option. I have never had a patient who I've seen like this that turned down an operation because he needs a foot that's flat. Even if he needs to be braced the rest of his life, even if he does, he'll do so much better with a foot that's flat in the brace. Otherwise, it's like this, right? Sticking a triangular shaped foot into a hole that doesn't match it. All right. This is a gal from Australia. I never saw her as a patient. She said, I'm told there's nothing to do for me, doctor. You know, I live in a brace. And I tried to give her the name of a surgeon in Australia who might help her, but she was told there was nothing to do. I mean, in all honesty, in certain patients, they would be better off with an amputation of their left leg. I mean, you all see with a good below-the-knee prosthesis, what people do, they go back to the army, they hike mountains. I would never suggest that because her foot can be brought flat with surgery. But I tried to get her here to this country, but it wasn't possible. Let's just see. So this yellow fellow was from Israel. Both feet were like the left foot. He was in a wheelchair. You understand the story now. I'm sorry, there's no way we could help you. He hadn't walked. He hadn't walked since probably the age of 10 years old. He left the office with a walker. It was very gratifying. So if we're doing surgery for patients who want surgery or need surgery, and for doctors who are going to do it, there are three main goals. It's really very simple, actually. What do we need? What do you want? You want a foot that's flat on the ground. Even if you have to be braced, it's flat in the brace with those without high stress areas. You want an ankle that's stable. How many people in the audience have CMT that if they don't wear a brace, keep tripping? Of course, because the muscles are weak on the outside of the ankle. And you need to like to have no braces. Nobody wants to wear a brace if you don't have to. So with the right tendon transfers in many patients, we can eliminate the foot drop and eliminate the braces, or at least minimize the braces, go from a bulky brace to a much smaller one. Now, this is a joke, this slide, but the controversies in surgery are extensive. You know, one person thinks green, one person thinks white. I mean, surgery controversy in the world and about CMT is probably as different as Donald Trump and President Biden, you know, and you know their differences. So what I did several years ago with the help of the Charcot-Marie-Tooth Association is I got together 14 or 15 of the smartest people I knew about CMT in the United States. We met in Chicago. The CMTA, the Charcot-Marie-Tooth Association, locked us in a room and said, you're not getting out until you come up with a consensus statement. This is available online to see for surgeons that are interested or patients that want to be smart about what surgery they might need. And it's, I think, excellent document. It took several years to produce. The key issues here, I think, from this document are two. One is there's a specific sequence of the surgical procedure. And I learned something myself from this group in reading the document over. You have to do things in a certain way to get the best results, and also do surgery as soon as possible. People say, when should I do it? The day that you wake up, or the day that your child wakes up, and you know you can't live with that foot the rest of your life because of its crooked posture, that's the day you should see a surgeon. And if you see one surgeon and they say there's nothing to do, then see the next and the next and the next until you find someone who'll help you. Ideally, somebody who knows CMT surgery. I used to say it would be nice if you met a surgeon who does at least one CMT surgery a month. That could be very difficult. Last year, we did 70 CMT surgeries. That's a really huge number. And it's taken, you won't find that probably in most places, but try to find someone who has experience with this. Now, since that consensus statement paper, we've done several studies here at Cedars that have proven out what all of us knew clinically. This paper that just came out last year shows that the longer there's abnormal pull on a bone during development, during adolescence, the more the bone becomes deformed. Well, that's not surprising. So the earlier you do it, the less deformity. This paper showed the extreme contractures and where they occur by delaying the surgery longer in life. So how do we do an operation? Everyone goes to sleep. They get a regional popliteal block, a shot around the knee when they're asleep. That gives short relief of pain. And then we put indwelling nerve catheters. They're not available everywhere. They're not critical. But if you're doing the surgery as an outpatient, it's very helpful. It's a little pain pump. It's a little pump filled with pain fluid. You push the button and it's infused around the nerve. That lasts 3 or 4 days. We have a big team of people who do this. I use loop magnification. As I said, I used to be a hand surgeon. The surgery is vast. On Wednesday, I revised a 10-year-old surgery. She'd been operated on in Florida. It took 6 hours with probably over 14 different procedures that we did. So the sequence here of the surgery for me is very important. The first thing that has to be done is to release all of the contracted tissues. You really don't know, or I don't know, what to do with the bone until all of the soft tissues are released. That includes Achilles tendon, plantar fascia, midfoot structures, contracted tendons. After that, we cut the bones and we shift them. Fixing the heel bone and getting the heel from an inturned varus position to a valgus position is very difficult often. And there's some nice papers we published on how to do those bone cuts. I'd advise someone looking those up if they're interested in this type of surgery. And then you have to balance the muscles. The most common problem that I see is the muscles have not been balanced adequately after the surgery. And you see these, oh, so sad, the patients, they've gone through a big surgery, they've rehabilitated for 6-8 months, only to have the problem come back again. Many surgeons think there's one way to do this surgery. I would just suggest that with 13 or 14 different procedures and variables, each case is very unique. How much bone to remove, how tight to make the tendon transfer, what soft tissue to release. Close your eyes. I'm going to show surgical pictures. If you don't want to see blood and guts and bones moving around, close your eyes for a little while. We don't need somebody fainting in the audience. So, soft tissue releases. The plantar fascia will get cut. The Achilles will be lengthened in almost all cases. The toe tendons get contracted, and we release those percutaneously. Here, the posterior tibial tendon has been elevated on the medial side of the foot, and we're releasing all of the contractures in the midfoot. You know how these feet are adducted or twisted around? We have to release that. This, for the surgeons in the room, is very similar to approach of a club foot. The spring ligament is taken down, the talonavicular capsule, but leave the subtalar joint. I've had overcorrections when I've released the subtalar joint. And here you can see a bone wedge taken out of the heel. And we can shift this bone. We can rotate the tuberosity of the calcaneus. The soft tissue has been released above and below. Often these patients will have an additional plantar fascia release here to get this corrected. All right. And here, the final one is the type of tendon transfers that can be done. This person has a drop foot. Their posterior tibial tendon was not working for the transfer. So we've transferred the flexor digitorum longus and the flexor hallucis longus through the interosseous membrane, and she did quite well. So you use what you can to get these transfers to work. You can open your eyes now if they've been closed, promise. Okay. So is the surgery worth it? There's risk. Absolutely. It's 100% worth it. I can look any patient who's got a crooked foot in the eye in your audience and tell you, I guarantee you that you'll be better. I don't know how much you'll be better. I don't know if it'll be better for 20 years because CMT is considered a progressive disease. But in my lifetime, my career time so far, being very active with hundreds of cases, especially over the past 20 years, I've been in California the whole time. And I don't really hear from patients that say, oh, my significant deformity has come back. Some patients need a fusion, a limited fusion. Never fuse the ankle in a CMT patient. It's the ankle that goes up and down. Much better if you can to have a ground reaction brace because it gives you fluidity of gait. But the bones in the bottom of the foot, the subtalar joint, it's fine to fuse these if you need to. But I can promise everyone they'll be better. It's just a question of how much better. Now let's just take a look and we'll finish up. And what I've done here is I have no desire to give you false hope. I have absolutely no desire to do an operation on somebody I won't help. What's the point? I'll probably get my last contract for 5 years in a year, maybe my last one, and I get a paycheck every 2 weeks. Why do I need to operate on somebody who I'm going to make worse? That's the worst thing that can happen to me at Cedars. But take a look. Both of these feet were the same before surgery, 17 years old. Right.
Hi, my name's Alma, and I'm going to have surgery with Dr. Pfeffer.
This is a different
and like
patient.
He always says, you can't put a crooked foot into an AFO or a brace. When I first got it, I was very excited because I thought, okay, this is going to work out perfectly. But it actually just causes more pain because my foot is crooked in it. you would think that it would be helpful, but it's not.
So that was a different patient, another one. This gal's from Boston. She's a nurse at Boston Children's Hospital. She looked at all the major hospitals in Boston, including Mass General, and I must say I was very honored that she came out here for surgery. Oh,
Hi.
I'm sorry about that. Different patient. This is a man, you'll see her in a minute. This is a man I just saw in the office yesterday.
Hi, my name is Alex. I'm from New Jersey. I've had CMT since adolescence. I'm 40 years old now. And biggest thing for me with this disorder and even the surgery was the leap of faith that it takes to get done. Sorry, man, it's like making me. It's a big deal, and if I was going to have even a sliver of normalcy, I knew I had to get this surgery done. I want to be able to spend time with my kids, do these basic things with my kids, and the way things are going, that was not going to be the case after a couple of years. So it makes it all worth it to me.
So I showed this video to my wife last night. I said, should I keep this put this in my talk? She says, well, it doesn't look that different, the two sides, but for anyone who has CMT in the audience, you know how different these are. Every time he steps up, he rolls his ankle like that very first video I showed. Now he's stable. He's had no fusions. He's had Achilles lengthening, plantar fascia release, percutaneous flexor tenotomies of the toes, calcaneal osteotomy, midfoot release, posterior tibial tendon, flexor hallucis longus to the peroneus brevis behind the leg, because he had no perineal function at all. First, I'll transfer the longus to the brevis. If that's not available, I'll use the flexor hallucis longus to the peroneus brevis. If that's not available, I'll use the flexor digitorum longus to the brevis. And if that's not available, I'll fuse the subtalar joint or the transverse tarsal joint. This is the nurse I was talking about.
Hi, my name is Glorya. I'm from Boston. I'm a nurse and I'm a person with CMT. I'm also a parent of a child with CMT. I was diagnosed 4 years ago at my first appointment with my doctor for CMT for my foot deformities. The very first time I met them, they said, great, we're going to get you fitted for your AFO braces that you'll have to wear basically forever. And that was extremely overwhelming to me. And I began pursuing other options. So I came out here to Cedars-Sinai in November. I had my first foot operated on, and it was truly a miracle. I think when you see the difference between my foot without the surgery and my foot with the surgery, you'll notice right away how good, how straight, how much better my foot looks, thanks to Dr. Pfeffer and the amazing team here at Cedars-Sinai. So I just really encourage anyone, a patient, a parent of somebody with CMT, to really look into other options, especially surgery here.
Now, she had no fusions, and I want to make two things clear in my last minute or two. I'm not against doing fusions, triple arthrodesis, subtalar fusion, and the surgeons in the room understand what I'm saying. And there's nothing wrong with a well-done fusion, but it's better not to have it. I'll just say parenthetically, I was born with a subtalar fusion. I have a coalition. I have no side-to-side motion in my heel. I think part of the reason that I so understand CMT patients is because I never knew what was wrong with me. I was screamed at in soccer. I was an incredible athlete going to my right, but not to my left, because I have this coalition. But there's nothing wrong with having a isolated fusion. And the other thing is, this is not a talk about anti-braces. I send people for CMT braces probably 3 times a week, but this is a talk about pro-surgery for the right person and giving a patient a choice, if possible. These people came from long distances and they had not been given a choice. And I think anyone looking at this would say that the choice they made was a good one. And these are not just isolated cases. These are good results. But as I said, most patients can expect to have some great benefit from having a foot that's flat on the ground. This 38-year-old woman has CMT. She's been operated on 3 times on the left side. And for the surgeons in the room, what you see there is an inguinal skin graft, because people thought that, well, they would transfer lymph nodes to her lateral foot from the inguinal area to decrease the swelling, when of course the problem was from the CMT. Here she is post-operatively. She came into my office and she said, Dr. Pfeffer, I have body hair growing on my ankle because I've had a skin graft taken from, up by my abdomen. And that was actually done right here at Cedars-Sinai by someone. So it shows you, it just shows you the variability and understanding of this disease. This is little Emma from Boston. Look at her left foot. She was told at Boston Children's Hospital that she had to be in braces the rest of her life. Here she is 4 months, only 4 months after her surgery. Another patient. And I'll be done here just in about a minute for those who are timing me. This young man from Kentucky on our East Coast, I saw him, he'd had failed surgery on the right. The night before surgery, about 10 o'clock, I got paged from the hospital. He wanted to talk to me. He said, Dr. Pfeffer, I've thought about it. If you want to amputate my leg tomorrow, you can. I've just really had enough of this. I can't go through another failure. Well, we didn't do that. And about 9 months later, I got this video from him with a little note that said, thank you so much. I just walked through the snow for the first time in my life with my children. Why would I retire?
Hi, my name is Jillian, and I'm 12 years old. And I came here in Cedars-Sinai to get my surgery done. And my feet, it looks wonderful. And now it's flat on the ground, not like the other feet. And the other feet is like bad. And this side is now amazing.
How was the surgery?
It was great.
Did you have a lot of pain?
No, it wasn't that much pain.
The pain pump helped?
Yes.
That was 2 weeks after surgery. Here she is out of her cast 4 months after surgery. Clearly the left has been operated on. The right's about to be operated on the next day. So my point here is she won't need a brace, I don't think, unless her CMT disease progresses. But even if she does, it's clear the benefits from surgery. And then finally, the surgery work. Does it last? It's a progressive disease, people say. But if you start at C+ and you get worse, you end up at an F. If I can get someone to be up at a B+ or an A-, the worst that might happen is they'll end up down at a C+. But I think the surgery does persevere. We're doing a lot of studies on this. And I would just finally say that actually you're the first people to know about this. We're going to submit it next month. We just finished the study. It's the largest follow-up of CMT surgery using patient-reported outcome measure information system, which is the NIH-sponsored PROMISE scores that many of you know. We looked at CMT patients 1 year after their surgery with physical function, pain, and mood and depression. And every single one of these 72 patients were statistically improved. And that's for 1 year. We'll see what happens at 5 and 10. But certainly it's very, very promising results. That's it. Thank you very much.
Thank you very much, Glenn. Would you have a couple of minutes for some questions? Maybe we have some questions from the audience.
I'm wide awake now.
Thank you very much.
Any questions from the audience to the speaker?
I think I will start while the others are thinking. Is it true that you've been a magician when you were much younger?
Well, I still am a magician. Yes, I don't mean about surgery. Yes, I used to perform at nightclubs, and I still do magic. I have half a room filled with magic tricks. And during COVID, I used to put on virtual magic shows for people. I love magic. I used to own doves and rabbits, and I would levitate and chop people in half.
This is in a way magic as well, what you do. We have a question.
Hey, Mr. Pfeffer, I'm Tamás Terebessy from the Summers University Department of Orthopedics. I'm a pediatric orthopedic surgeon. And I have a special question to you. Maybe it's a bit too orthopedic, but the audience is not only specialists, so sorry about this question. But you mentioned that every case is unique and every surgery is unique. That how would you decide which soft tissue should be released, or every time you have to release all that you mentioned?
Mm-hmm. No, it's a superb question, and it's an honor to meet you and to be part of this program. I'm really excited by it. You'll understand exactly what I mean. I'm talking to a friend of mine who's a trauma surgeon here, right? And he goes, I know what to do with CMT. He said, you transfer the posterior tibial tendon to the top of the foot, you transfer the longus to the brevis, and you cut the plantar fascia. And you lift up the first ray, right, with an osteotomy. I said, yeah, that's certainly what you do. He said, what's the big deal? So, as you know, each of these cases present very differently. And the demyelinating ones, the CMT 1As, I think, are a little more consistent, but the 2s and the axonal CMT types present in a very unusual fashion. So what I'll do is, for me, for the sake of time, the Achilles almost always has to be lengthened. Not because it's causing an equinus, but because the Achilles inserts medially and it's causing a varus deformity. Very controversial in this country, but I would say 95% of my cases I do a Hoke lengthening and I leave the lateralmost portion of the Achilles intact. Then I'll make an incision along the medial foot, right? And I'll look at the posterior tibial tendon. The key there is to get enough length. Most people here don't. John Su, one of the great pediatric orthopedic people, you know, the generation before me, taught me this. And that's dissect the posterior tibial tendon all the way out to the cuneiform. Maybe you do this, but we'll actually lift a little bit of the navicular and then we tubularize the tendon and put a suture on it. But if I don't get that extra inch, which I will do by dissecting the tendon all the way out to the cuneiform, I don't have enough length to put the right tension on it. Next, so that helps, right? We're desupinating the foot. Then I'll put always almost, you have the adduction, like a club foot, you know better than I do. I'll go into the talonavicular joint and release it. I released the subtalar joint in a few patients and I got overcorrections, particularly in these hyperlax, young children. I'll divide the spring ligament and I'll make sure all of the expansion of the posterior tibial tendon is released. I'll release some of whatever plantar structures there are that need to be released. So let's see, then we'll bring up the tendon and bring it to the side of the foot. The plantar fascia, it's interesting, especially if there's significant depression of the first ray, or valgus of the forefoot. I'll release the plantar fascia in the midfoot. You could do it, you may, a lot of the pediatric people do through the medial side, but I'll make a separate incision here. I'll often release the plantar fascia also underneath the calcaneus, which I'll get to in a minute, but we'll release the plantar fascia. So let's see, that really is the soft tissue releases I do. And then when we cut the calcaneus, which doesn't always have to be done, but when it does, I'll release all the soft tissue around the tuberosity, because some of these are very difficult. So I'll do a Dwyer, release all the soft tissue, if in the worst cases, translate it laterally and also rotate the heel, because it's completely free, the tuberosity then. You just have to watch out for overcorrection. And then, of course, the first ray with a cuneiform opening wedge osteotomy or a closing wedge osteotomy of the metatarsal. And then often we'll do percutaneous flexor tenotomies. I don't like weakening the foot, but I think if you divide the flexors and the toes, they still keep flexion power, right? Because they don't contract that much, the tendons. Does that help? Or does that give you my thought process?
It is. Thank you very much, the detailed answer.
Hi, this is Julachadi. I'm a pediatric neurologist at Connecticut Children's, and I'm just here. And so I have a non-surgical question. Do you use any long-term or immediate outcome measures that so you can then systemically report and compare your cases and the success of the treatment? And like my colleague Kristen Pierce uses gait analysis to monitor pre-surgically, post-surgically, more quantitatively the outcome of surgeries.
Well, that's a great question. First of all, I just emailed, you probably know Bob Kay, right, who's now head of orthopedics here at Children's Hospital. I just spoke to Bob last week, and I said, Bob, do you think the pediatric orthopedists, and pediatric neurologists would be interested in doing like a consensus type meeting the way that we did for adults? And he just emailed, I just saw an email to Kristen there where you are. And if you guys are interested, I'd love to help with that. We'll get you and Kristen and maybe 10 other people in the country or world together and work on a consensus statement for pediatrics. For us, most of my patients are from out of state, right? Many of them are some of them are from out of the country. Each year there are probably 5 or 6 people from out of the country. So it's impossible for me to get x-rays and follow them up. But what we do is we get weight-bearing CAT scans on all patients preoperatively. And when patients come back to have the other foot, we get another weight-bearing CAT scan of the same foot to sort of see how I did. And we're just going to publish that data to see how good the correction is. But the PROMIS scores, which you know about, I think are really the best for this particular disease. Dr. Shai has, what's it called, the CMT evaluation. But I can't do that because we can't do any type of gait analysis because the patients aren't here. But I think the PROMIS is good because for people in the audience, what the PROMIS does, and it's as good as we get in terms of patient-reported outcomes, it's sponsored by the National Institute of Health, is it lets us know what the function is. So whether or not the person's a little weak, if their function is better, then that's a great outcome from surgery. Whether the talonavicular joint is reduced or whether their gait, a gait lab would be wonderful. But I'm very pleased with the PROMIS. So we get that at every visit. And on the study we're going to publish, the expression, it was like pulling teeth, but we got in touch with all these patients around the world to see how they were doing with their PROMIS scores. So that's a long answer, but what we use is PROMIS, and we use x-rays where possible. I tried to do a gait study, but it was impossible because I'm pre and post-op. You guys should do that, pre and post-op gait study if you haven't already.
Thank you. And as part of the the Neuropathy Consortium, we are happy to participate in that consensus studies.
Well, you might, yes, this is wonderful actually, because Rich Davidson, who's an orthopedic surgeon at CHOP, who helped train me, he said, you should get in touch with the people at UConn because they're interested in this. And so if you happen to mention to her that we met, and she got this email out of the blue, and you would come, maybe another pediatric neurologist, I hope, and then you get 10 pediatric orthopedic surgeons in the room. Because what the pedipod's, the pediatric orthopedic surgeons do is actually quite different than what the adults do. And I think we can both learn from each other.
Thank you very much, Glenn. Thank you. We had a question that we received during the registration, and it's about the age of your patients. You mentioned also during your presentation that it's better to have surgery done at a younger age. Is there a specific age, or is there a reason within aging why you say that? I mean, is puberty influencing this, or? Another
brilliant question, and there's absolutely no answer to it. we're just publishing a big paper in the major orthopedic literature. I was very proud. It was accepted in our JOS, the Yellow Journal. And basically, it's based on the literature, but also on the experience that we have, with hundreds of patients. So what I found with that is, A, things get worse during puberty. They really can accelerate. The neurologist can maybe explain to us why, in many patients. So if I see someone just at the beginning of puberty and they're not that bad yet, they're not that crooked, we'll wait, because you really want to see what you're going to get in a couple of years. I operated on an 11-year-old girl this week, but she's really a young woman already. She's not, her physes are closing. And so the key, though, is to operate, I think, as soon as the deformity starts to present itself and prevents bracing in a comfortable way. Because if you have a foot like this and you can brace it comfortably like this, well, that's fine. Brace the foot until the person goes through adolescence. But so many people can't have their foot braced without pain. They also become self-conscious as they get older, through adolescence. And we'll do surgery as soon as it starts to become impossible for bracing. I know some people have operated on 4-year-olds, 5-year-olds. I've never operated myself on anyone younger than 7. Remember that girl on the beach? I showed the picture there. She really couldn't be braced. And the surgery was life-changing for her. If nothing else, she'll probably forget about it for the foot she had by the time she's reaching puberty and worried about whether or not the guy she likes her.
Thank you very much, Glenn. Van még bárkinek kérdése? Thank you, Glenn. I think this was it all. Thank you very much again for starting your weekend with us and being here. We really appreciate it.
Well, it's a great honor. I wish I understood the last talk, but it looked like an excellent talk that you had on the spine from the pediatric person.
Hopefully next time we can have you here by person, and then you can enjoy everything from beginning to the end.
Thank you for inviting me.
Enjoy your weekend. Bye-bye.